Okay, so we're off to the next section, wellness and longevity risk factors. And you have to remember that one of the main risk factors for longevity is developing a disease. And not having disease is the term where it is defined as having wellness. Now remember, everyone defines wellness differently, but as far as the aging medicine goes, wellness is just simply no disease. Now, in this section, there's a couple goals. The clinical objectives or review how to clinically identify the most common diseases that impact longevity, review how to clinically identify patterns associated with loss of physiological resiliency. And then the academic goal is just to review the literature, review the most common diseases that impact longevity, and review the principles of physiological resiliency from an academic principle. But ultimately, as a clinician, you're trying to look at a couple things. First of all, you're trying to figure out if there's any early signs of geroscience implications happening, right? Where people start to get mitochondrial dysfunction, where people start to have epigenetic factors involved, where people start to have inflammation, all those things. And your biggest clue of that happening is when they start to lose resiliency. So evaluating different forms of resiliency is a big part of the structure of looking at longevity medicine. The other part of it is really looking at, do they have disease? And some of these issues with resiliency, there's no early signs until they actually develop disease. We know the healthy person that they're an athlete, they're doing well, and all of a sudden they have malignancy, all of a sudden they have a heart attack. So we don't always clearly see resiliency loss before disease, but we do see some suggestions of it. And certainly if you're losing resiliency, you're having some of the hallmarks of aging being expressed. So here's the diagram that kind of simplifies that concept. Wellness and longevity factors. Wellness risk equals development of disease. Longevity risk factors, loss of resiliency. And remember, the ultimate goal is to have someone live as long as they can without morbidity until the very last parts of their life. Using 100 years old is a common goal, and that's used in longevity medicine. And here we see what we don't want. We don't want someone developing morbidity early. So there's a concept called shifting morbidity to the right of the lifespan scale. You can see this one's shifted to the left, where they're having morbidity very early on, instead of having it on later, which would be a shift to the right. And then here you can see another issue that's very common these days, where people start to get disease and loss of function, let's say at age 50, and then they have 50 years of morbidity where they have problems. And this is definitely happening with aging parents that have mild cognitive impairment that can't function at work anymore, and they're counting on their family members to help them. And this is going to be an ongoing issue, and it's also a concern for just the healthcare system itself, as well as families and their financial resources. Okay, now there's some studies done looking at longevity medicine. One of the ones that was very well done, and we should talk about, is this Dunedin longitudinal study. And in this study, they recruited 1,037 individuals born in Dunedin, New Zealand, from 1972 to 1973. And the participants were followed longitudinally, and beginning at age 26, investigators began collecting biomarkers that reflected a wide range of organ system functions. The measures were repeated at age 32, 38, and 45, allowing them to assess how rates of change were called the pace of aging. So they followed these 1,000 subjects, from, age 26, their mid-20s, all the way into their midlife, mid-40s. And they looked at 19 different markers. And they also did some brain imaging scans on these dates that when they were 26, 32, 38, 45. And they did some laboratory markers, and they wanted to see what are the expressions of aging, what's the pace of aging, how do people poor age, and more importantly, what are some of the earliest findings that people are aging poorly, and what are the association correlations? And in their study, and the paper is included, you'll find the paper online, it's also in your course materials. But if you look at the paper, they have this great chart, and you look at the variables they were looking at from age 26 to 45 in these 1,000 subjects. They're looking at BMI, waist-to-hip ratios, hemoglobin A1C, leptin, mean arterial pressure, VO2 max, FE, forced expiratory volume, 1 second, total cholesterol, triglycerides, HDL, lipoprotein, A, ApoB, glomerular filtration rate, blood urea nitrogen, highly sensitive reactive protein, white blood cell count, mean periodontal attachment loss, dental care experiences. So it's pretty good. And they also did brain scans to look at their brain volumes throughout this period and some neurocognitive testing. And for the most part, if you look at these biomarkers, at age 26 and age 45, they're all getting worse, which is typical, expected when you're looking at just 1,000 people over a period of time. So all the markers to some degree got worse, and what they were looking at those that were pacing faster, but these markers got worse much faster compared to the other groups of people. And then the model they used is with these 19 markers, we're looking at cardiovascular function, metabolic function, renal function, immune function, dental health, pulmonary function, and then we can see how these markers are causing changes in their neuroimaging test, looking at gray and white matter measurements, looking at their cognitive difficulties, looking at their functional fitness, and so forth, and then also perceptions of aging, their attitudes of how things are going. So they did this study, and then there's some interesting things that they found with this study. So let's go through that. So they go on and say that age 45 in 2019 participants with faster pace aging had more cognitive difficulties, signs of advanced brain aging, diminished sensory motor functions, older appearances, and more pessimistic perceptions of aging. And that was the key thing. So of all the markers they looked at, the ones that really indicated, and this is important for us as clinicians, like how do you really know if someone's really aging poorly? Well, first of all, one of the very clear signs where there was correlation between all these other markers was the cognitive difficulties. So cognitive difficulties are not going to be totally functioning and normal one day and then they have dementia the next day. Cognitive difficulties will be, I can't think as long as I used to, or concentrate as long as I used to. I don't have focus, I don't have attention. I have to write everything down. I need to use navigation system. Those are the things that were very good signs of cognitive decline. So age 45. So if you're having cognitive declines at age 45, that's one of the signs of having very poor aging compared to other people. Diminished sensory motor functions, so just coordination, motor function. And then the other thing was just older appearances. They just looked older. And this is an ongoing thing, is appearance and just how someone looks, like their aging seems to be a very predictive marker of how they are actually aging. And then having pessimistic perceptions of aging, of how they feel, what the future holds, was another key sign of poor aging. And then if you look at some of the data that they published in their study, they can see the ones that were aging poorly, they looked at their cortical thickness, they had less cortical thickness, their surface areas were compromised. That was one of the clear findings of people aging poorly, even though they were looking at all these other markers, looking at renal function and kidney, lung function and inflammatory markers and so forth. And another one was just their actual perceived age of how they look. So these individuals are all 45 years old, right? But the one on the left is not the same as the one on the right. The one on the left looks much younger, even though they're both 45, these females. These males are both 45 years old. This guy looks much younger than this guy. They're not the same people. Like, they have similarity traits, but they're different people. So you can see that, appearance of age is a key factor. So the older someone looks is a great indication of how it's actually happening with their cellular and physiological functions. So that's important to know as clinicians. As clinicians, again, we talked about when we get into the physical examination of how to evaluate longevity and aging and the expression of these hallmarks of aging, cognitive function becomes really, really important. Physical appearance becomes really important, and psychological resiliency becomes very important as well. Okay. Now, when we look at these factors, we spend a lot of time, Master Justice's review, going over what the field of geroscience uses called hallmarks of aging and pillars of aging. And the theory being that, whether you categorize the physiology that's happening as the hallmarks of aging or pillars of aging, these mechanisms are taking place first, and then they're leading to disease, and these diseases are not independent of each other. It's just expressions of these various features in different tissues. So mitochondrial dysfunction and loss of proteostasis and stem cell exhaustion, that could easily be Alzheimer's disease, or that could easily be cataracts, or that could easily be mechanisms that lead into cancer, or those definitely could be mechanisms that are involved with COPD. right? There could be local effects. Like, for example, if someone's smoking and they're a smoker all the time, they're going to get that free radical exposure from smoking, causing genetic instability at a greater rate in their lung tissue, which makes them more prone to having their cellular senescence, immune cell exhaustion, and their lung tissue expressed first before other tissues, even though it's happening throughout their whole body. So this is like where they look at cancer as being a factor there. People that have high amounts of sugar and glycemic index type foods and have lack of physical activity, and they're causing insulin surges, they're when you look at their islet cells of the pancreas and their pancreatic function, they are having mitochondrial dysfunctions. They are having immune senescence. They're having stem cell exhaustion. So they can see features of these changes in each of those specific diseases. So the whole concept of geroscience is that, when you look at aging is not individual diseases, but it's really a pathophysiology of these mechanisms that could be expressed further in tissues earlier than later based on other variable stressors that are being pushed on it, but ultimately it's these mechanisms that are involved. And then when these mechanisms take place, there's DNA damage and telomere shortening and epigenetic expressions, oncogene induction and reactive metabolites. These normal cells in the tissue become senescent cells. There's severe inflammation in the tissues, and then the stem cells that are there are no longer responsive. So you can take it, for example, let's look at a smoker. A smoker has free radical damage, DNA damage, telomere shortening, epigenetic dysregulation, greater expression of that will be in their lung tissue. So the lung tissue gets senescent cells first because that direct exposure of DNA damage to those tissues. And then over a period of time, their lungs get inflamed. They have symptoms. They can't breathe. They get restrictive patterns. They end up with lung cancer. If you look at someone who's got CTE, chronic traumatic encephalopathy, they get brain injury. They get traumatic injury to the brain gets inflamed. Those inflammatory reactions create inflammation. Those free radical inflammatory responses will cause DNA damage, telomere shortening, epigenetic dysregulation, mitochondrial uncoupling. They get senescent cells, like a protein aggregation. They get inflammation in the brain, inflammaging in their brain. Stem cells get exhausted, especially in the hippocampus. And then they progress into dementia and Alzheimer's disease. So these mechanisms are all the same, are all fundamentally the same when you look at the field of geroscience. These things are actually happening. And the goal of geroscience is obviously to optimize each of these physiological functions as early as possible throughout our lifespan. And then they're also looking at making drugs and looking at how different nutraceuticals and different lifestyle factors impact those. So these hallmarks of aging are really important for us. And as we get into clinical application and treatment, we want to talk about them. But the point to us as clinicians is, how do we see these hallmarks of aging express? Well, one of them will be they lose function. We see loss of resilience in the early stages. And other times, it'll be right into that they just develop a disease. And they actually have disease development. And they've gone through this process, and we talked about the most common cause of death in the U.S. and Europe, and it's pretty similar throughout the world. Modern civilizations, modern countries, industries, and so forth. And here they are: cancer, COPD, CK, CVD, diabetes, dementia, and so forth. And then longevity risk factors is another key area where we'll see these physiological hallmarks of aging express, and that's where before they get into disease and they start to lose function, that's where we'll see genome instability and telomere attrition and so forth. And then different people have different degrees of resiliency for different patterns that are involved with their clinical presentations. Now, I have to point out, when you start to see loss of resiliency as people start to age, you have to know that's going to have a direct impact as a clinician for you of outcomes. Whenever you're working with a patient and you come up with a working diagnosis of mechanisms you want to try to improve, it's always a working theory until they actually respond. So when you get to the situation where a patient doesn't respond, you always have to question, is my diagnosis wrong? Did I miss something, right? Or is there other things happening that I may not be aware of, or is this, they just don't have the function to respond anymore? So let's just take someone who's got a chronic pain syndrome. Say someone's got chronic pain, they're just inflamed all the time, their joints hurt, the body hurts, then they have like depression, right? So let's say someone with some mild depression, lack of motivation, brain fog, and body aches and pains, right? Typically, a typical person that seeks someone who's practicing functional medicine. They don't have clear disease yet, but they just have brain fog and depression, a little bit of, and not major depressive depression, but just a little bit of depression, and some body aches and pains, and just feel like they're not functioning as well as they used to. So if you see that in a 20-year-old, that's different than seeing that in a 40-year-old or a 60-year-old or an 80-year-old. And the older they are, the more likely is that they have some of these hallmarks of aging that are taking place. But you could expect all these hallmarks of aging to start showing up with people right around age 40. So they can be expressed pretty early, and you can see some of those at age 40. So you have someone who's got, all these signs of inflammation, brain inflammation like brain fog and body aches and pains and systemic joint muscle inflammation. And you do your thing. Maybe do a workup, and maybe you start looking at their microbiome, and you try to optimize your microbiome health and start to change your diet. And maybe you find they have some leaky gut. Maybe they have some food intolerances. Maybe you put on some natural nutraceuticals, anti-inflammatories. And maybe you get some change, and maybe you don't. And that's the key thing is if you don't, there's a possibility that your diagnosis is wrong, or they just lost their capacity to respond, and they really have expression of these hallmarks of aging. And the point of this course is to go, hey, maybe in that person, you're going to have to go into these hallmarks of aging a little bit deeper and really try to look at all the resiliency patterns and improve the resiliency and see if you can make a change with that. And I think working with chronic patients, you're going to see this becomes a necessary step in many instances. And when we go through case studies and evaluation treatment, hopefully it'll be made more clear. So what I'm trying to say is the applications of geroscience isn't just waiting to see if someone lives longer. The application is also involved with chronic disease, because as geroscience expressions start happening, people start developing disease and people start having different types of symptoms. Okay, so when we look at wellness and risk disease development, these are the most common causes of disease. So let's focus on these for a second. Remember, for every single condition a person gets, that just changes their life expectancy X amount of years. The main study that looked at this was looking at people age 67, and for each additional, condition that they developed, their life expectancy went down dramatically. Okay, so we know when we look at these top 10 causes of disease, the traditional physical exam is not very effective. We're going to go into how to do a very thorough evaluation of actually looking at predictive markers for all the main causes of disease that can take place as we get older and as we age. And let's just talk about cardiovascular disease for a second. And what I want to do is I want to go over the top 10 conditions that people face and most likely you're going to have in your practice, and then talk to you about why does geroscience believe that their pathophysiology is involved with causing these diseases. Well, the reality is, when you look at cardiovascular diseases, the changes that take place in the blood vessels are all associated with changes that geroscience has explained, and same with all the other top 10 conditions as well. So, when you look at the classical warning signs of cardiovascular disease, the shortness of breath and chest tightness and pain and numbness or coldness in their legs or arms, but it's really a silent killer. There aren't any clear symptoms. That's one of the two concerns about it. The two main causes of death that will impact longevity are cancer and cardiovascular disease, and both are silent until the very last end stages. So vascular disease, number one killer worldwide. 85% of deaths are due to myocardial infarction, 50% are due to stroke. And ultimately what's happening is their blood vessels are becoming compromised. They're becoming injured. It's all about the vascular endothelium. And at the Krasien Institute course we did in cardiovascular disease, we went through very detailed step-by-step mechanisms of all the things that are happening to the vascular endothelium, and how vascular disease is really destruction of these cells in the blood vessels. But the bottom line is these arteries all have these endothelial cells, and these endothelial cells produce things like nitric oxide and vascular endothelial growth factor and other compounds, and they help with vascular dynamics and blood flow and circulation. But these cells are prone to getting injured and degenerated and inflamed and so-called aging through various mechanisms. And these endothelial cells can have all these different mechanisms start to cause injury to them. So when you look at things like cigarette smoke, air pollution, toxic chemicals, antioxidant depletion, elevated homocysteine, micrometabolites, medications, oxidative stress, those are all things that cause genome instability. Those are all the things that cause telomere attrition. Those are all the things that cause mitochondrial uncoupling. Those are all the things that damage cells in the area and lead to inflammation. So all the concepts of the hallmarks of aging really apply to atherosclerosis. And the risk factors that we know promote atherosclerosis are the same risk factors that are associated with the hallmarks of aging. And then once people start developing vascular disease is going to express throughout their body. They may have expressions in their coronary arteries first and have MI or chest pain. They may end up with just a stroke, or they may have peripheral arterial disease. They have leg cramping when they walk and things associated with that. There's a quote from 1624, "A person is as old as his arteries," which holds true today. Like you're only as old if your arteries are sick and clogged and injured. That's really your age span. So, and then also, even though people are looking at telomere strengths, in the field of geroscience, they are looking at aging of each individual tissue of the body. Like, what does an aged artery look like? What does an aged heart tissue look like? What does an aged muscles tissue look like? And there's very characteristic changes of them, and they have all the hallmarks of aging in them. The aged tissues, whether it's heart tissue or vascular endothelium tissue or neurons, they'll have lots of protein aggregation in there. They'll have mitochondrials that are not working. They have lots of senescent cells in those tissues, and they'll have immune stem cell exhaustion patterns that are taking place and so forth. So this is a paper that just really goes into and says, okay, when we look at vascular inflammation, what's really happening is really there's too much inflammation, not enough antioxidant properties, lots of senescent cells, things like infections can come in, things like toll-like receptor activators, which are known as danger-associated molecular pathways. Example of toll-like receptor activators would be like endotoxemia for leaky gut. So gram-negative bacteria that's released with intestinal permeability from dysbiosis and leaky gut combined together has been shown to bind to TLR4 receptors and cause inflammation throughout the body, including vascular inflammation. So, these vascular cells get inflamed, and, we kind of look at that from an inflammatory model and understand those mechanisms. But when you look at the field of geroscience, you're going, all the things that you're associating with vascular disease are really all still under the criteria of the hallmarks of aging. There is macromacular damage. There's not enough proteostasis. There's dead debris there. These cells are causing inflammation, the senescent cells, and all the other lifestyle factors that impact these other issues may also be impacting the vascular system as well. So when you have someone, for example, who's sedentary, one of the key features of someone who's sedentary compared to someone who's active is they don't have as much mitochondrial biogenesis, and it's in all their tissues. So people who are active have more mitochondrial activity, more mitochondrial biogenesis in their brain, in their skeletal muscle, in their liver, in their kidneys. Like every organ system, every tissue in the body is going to have more mitochondria just by the fact that they're moving, okay, compared to someone who's sedentary. So when we talk about, let's say, vascular disease, there's going to have less mitochondria also in their blood vessels. Now, if you combine that with someone who, for example, smokes and has free radicals that are directly damaging their vascular endothelium, or let's say they have cytomegalovirus infection. Cytomegalovirus cross-reacts with proteins of the vascular system. And that causes direct inflammation, injury to those cells and tissues, and starts to alter those cells and tissues' genome. And then this creates greater aging, combined with the fact that their pre-existing mitochondrial dysfunction was there. They're going to have the expressions of the hallmarks of aging show up in those tissues first. But if the person had greater mitochondrial integrity because they were moving, they may have more protection even though let's say they're a smoker, right? So that's the concept. So the hallmarks of aging you can see here are showing up in vascular aging and senescence. They can see that when they look at blood vessel health, They can see things like senescent cells that are releasing these senescent-associated secretory phenotypes, these inflammatory mediators, and then these inflammatory mediators are causing inflammation and destruction of those tissues. They'll see the mitochondrial impairment. There's the stem cell exhaustion of the endothelial cells. You can see here another great expression of this. So this was a study where they were looking at thoracic aortic aneurysms. And when they look at what's happening in the vascular system, they're getting senescent cells. They're getting mitochondrial cells that are compromised. They're getting stem cell exhaustion. They're getting these things that are then leading to ongoing inflammation, which then leads to stiffness and collagen and DNA damage. So your pre-existing expression of the hallmarks of aging really help either promote disease or prevent disease. And that's the key thing. So you can see, like, if you were to go back and go, okay, what's the cause of vascular disease? You can go, ultimately, your pre-existing hallmarks of aging are going to determine how different insults cause DNA damage and telomere attrition and so forth. The greater those functions are, the less, let's say, DNA damage you have, the more healthy mitochondria you have throughout your whole body, the greater stem cell function you have, the greater telomere links you have, the greater epigenetic expressions you have. Despite having insults or injury from various risk factors, the expression of disease will be less, right? So the goal is always to kind of reduce these hallmarks of aging. Cancer, second cause of death. Also, silent until it develops and progresses. And if you look at cancer throughout the world, the number one type of cancer is lung cancer. So this is lung cancer in the US, and then followed by colon cancer. So lung cancer, colon cancer in Europe and Central Asia, worldwide, lung cancer, colon cancer, right? Lung cancer being number one because there's so many smokers in the world. And then colon cancer because there's so much people that have intestinal inflammation and unhealthy guts. And it's very common for those things to then do what? Damage DNA, epigenetic changes, inflammatory responses, stem cell exhaustion. We can get into those. Now, obviously, the clear signs of red flags: persistent fatigue, unexplained weight loss, unusual lumps, loss of appetite, sores that don't heal, skin changes such as a rash or skin reddening. So as a clinician, you definitely have to be aware of those warning signs of cancer. Other key things you got to be really worried about is like white blood cells skyrocketing all of a sudden from one past lab test to the next. If you guys ever see that, that's a concern, especially if you see no signs of infection. White blood cells plummeting is another red flag for cancer. If you ever see a sudden drop of their cholesterol, like if it was 190 and now it's like 110 in a very short period of time, like in a month, that would be a red flag. If you see things like lymphocytes drop, that would be a red flag. If you see a sudden spike of globulin on a blood test, and if you start to see all those together, like globulin levels spike up, total cholesterol drop all of a sudden, see their white blood cells change, either really high or really low, those are all red flag with unexplained weight loss. But the thing you have to remember about cancer is that it's very, very clear. The sooner that it's addressed, the greater the chance of survival. So if you have 500 million cancer cells versus billions of cancer cells in your body, the outcomes are going to be completely different. The unfortunate thing is most cancer is silent. So when we get into the evaluation, one of the most important things we're going to talk about is what's called liquid biopsy. And liquid biopsy is now the ability to do blood tests to then check for fragments of cancer in blood, which has a really high predictive value. The only problem is it's like $1,000 to do, so it's not part of routine physical exams. But if you wanted to incorporate a liquid biopsy and screen for 60 cancers, it can be done. And one of the things that we'll talk about is how to develop a really thorough physical examination beyond the standard that's used today. And one of them will be using these liquid serum biopsy tools. And it's something you should do for yourself every year. You should really budget a certain amount of money you have for your own evaluation each year. Because in order for you to live longer, one of the key things is you have to identify disease as soon as possible so it can be addressed. Now, when you look at how the hallmarks of aging come into cancer pathophysiology, there's a mutation that inactivates tumor suppressor gene. Well, how does that mutation happen? That mutation happens when DNA gets damaged. So this goes back to genomic instability. So you have genomic instability, You have your telomeres that start to shorten, so your DNA is more prone to getting injury. So you're getting alterations, epigenetic effects. That's when you start to get mutation, and which inactivates tumor suppressor genes. Cells then proliferate, and then the mutation inactivates DNA repair. So now the cells can't repair, and then mutation of proto-oncogene creates an oncogene itself. And then that then inactivates more suppressive genes, and then cells become cancerous and they start to grow. But it all goes back to hallmarks of aging: genomic instability, telomere attrition, epigenetic expressions that then impact these senescent cells, stem cell immune exhaustion. They call immune senescence. Those are all parts of those mechanisms. Now here's a diagram that really looks at what's happening with stem cells over a lifespan. We have stem cells in all their tissues, and from birth through aging process, we're using some of these stem cells to become active. And when we end up with deficient stem cells or unhealthy stem cells, the normal healthy process is that they go through this autophagy pathway, through cellular apoptosis, and then they're destroyed. And what this diagram is showing is that if you have a lot of insult and injury and DNA damage over your lifespan, which is going to be from environmental toxins, endogenous inflammatory reactions, you're going to have less stem cells to support you as you get older. So you're more prone to degenerative diseases like degenerative joint disease or degeneration of your lung tissue and so forth. So the more DNA damage, the more accumulation of cellular damage you have, which will be from not having enough antioxidants in relation to the free radical exposure your body gets, you could definitely cause the aging process. And then here they also show that these, sometimes these defective stem cells don't properly go through apoptosis and get destroyed, but they mutate. And then they mutate and they become cancerous cells. And it really all goes back to maintaining the integrity of the DNA from being damaged. And it's really simple. Like they know the causes. It's toxic pollutants. It's ambient air pollution. It's chemicals that are in our food chain. Now, we're all going to all get those exposures, but it's really simple. The amount of antioxidants you have to quench those is the variable that changes the expression of those things. So people that are more health conscious would be okay taking antioxidants even though they don't notice immediate change in symptoms and how they function, and others won't. Okay. Here's a diagram that really is illustrating what's happening in the microenvironment that promotes tumor cells. And these go back to all the different hallmarks of aging. And here you can see they show normal tissue. And what they show is that in young individuals versus aged individuals, as their tissues express hallmarks of aging, they become more prone to having cancer development and progression. So here they illustrate fibroblasts. And fibroblasts are really responsible for regulating tissue and really releasing cytokines and chemokines and inflammatory mediators when there are potentially cancerous cells in the body. And here you can see everything's great. Looks like green is healthy function. And then what you can see here is with an aged environment, there's more of these senescent cells. These are cells that no longer go through cell division. They're not as efficient. They're not effective. So they're not going to do their job as well. And then the other thing that happens as people have hallmarks of aging express is they get immunosenescent. There's T cells, suppressor cells, helper cells, regulatory cells, dendritic cells, tumor cells, all become less active, less functional. So when you take a combination of more senescent cells and immune cells that aren't working and not being able to produce the quantity of them, once you do have damaged DNA that then leads to mutations, it just creates the environment for these cancer cells to progress. So once again, when you go deeper into what's the pathophysiology of cancer, where does it really start? It goes back to the hallmarks of aging being expressed. And they have the same thing showing changes in collagen and stiffened collagen with aging through the aging process. And this is the point. The point is, ultimately, when you go deeper into cancer pathophysiology, it's the hallmarks of aging that create the environment for cancer cells to change. And that's not the only thing. I mean, but it is a risk factor. It is a variable, because we can see obviously some tumors happen in young individuals unrelated to those things, but some of these young individuals have genetic susceptibility in combination with maybe the right triggers that turns on some of those. But for older individuals where you have the high spike of malignancy and cancer, hallmarks of aging definitely are a risk factor as they're being expressed. Now, you go into respiratory disease, obviously chronic cough, shortness of breath with little or no exertion, labored breathing, chronic mucus production, wheezing, coughing up blood even if a small amount, cyanosis, nail buds or lips. Respiratory disease is right up here. It's like the third cause of death. And then just look at all respiratory disease, and they also subdivide into low respiratory diseases. It's also in the top 10. And in the U.S., when we look at pulmonary disease, and also the fact that it's worldwide leading cause of death, the main ones are pulmonary edema, pneumonia, lung cancer. Lung cancer is the second most common cause of cancer. First, the highest rate of cancer death worldwide: emphysema, COPD, bronchitis, exhalation, asthma. And then when we look at lung tissues, one of the things that can happen with lung diseases is the structure of tissue is affected. They get scarring, and they get restrictive lung tissues. And this is going to take place when you start to have stem cell exhaustion and you start to have proteostasis. So the hallmarks of aging being expressed will cause and help promote restrictive lung diseases. They have airway diseases, carry oxygen, other gases into that. More of those, they get narrowed, they get blocked. And then as the immune system becomes less efficient in blocking immune responses, there's greater vasoactive properties that take place. And then blood vessels can get damaged and injured, all through the hallmarks of aging. So the different expressions of the hallmarks of aging are directly linked to airway disease, lung tissue diseases, and circulatory diseases. So the greater adverse effect someone has of hallmarks of aging, the more prone and risk they are for all types of lung diseases. And here you can see an illustration of that in this paper that was published called Cellular Senescence and Aging and Lung Disease. And they go on to say, listen, if you go deep enough to get the risk factor for lung disease, the things that are happening is we're getting, shifts in mitochondria. Mitochondria are not being produced as much as they used to. There's lack of fusion together with them. Telomere lengths are shortening. We directly look at lung tissue, because remember, when they measure telomere lengths for a lab test, they're looking at white blood cell telomeres. And there's some degree of association between white blood cell telomeres and other tissues, but you could have, let's say, greater telomere length loss in one tissue versus another issue as a consequence of aging. So even though there's high associations overall with them, but you might have a person, for example, who is a smoker, or a person who lives in a highly polluted area and breathes in air contaminants all the time. Their lung tissue telomere length could be much shorter than their white blood cell telomere length, but it's still an expression of the hallmark of aging. So they see those types of features. They see all these senescent cells, these cells that are no longer going through cell division, creating these inflammatory mediators involved, these SASPs, all as a consequence of a difference between a young lung versus an old lung that then develops disease. And then as you look at lung function, airway space changes, increased dysfunctional senescent cells, their increased size of elasticity, increased subcellular inflammation. So there's a permanent change to their lung anatomy. And this was just a great paper. If you want to read more about lung aging and frontiers in aging, it's in your course materials. But it goes into all the different actual changes they document that are taking place from the expressions of hallmarks of aging with lung function. And obviously there's changes in mitochondrial and tissue and protein aggregation and lack of autophagy, lack of mitophagy, immune senescence, all those things are taking place. So again, it goes back to, if you look at the common causes of death, whether it's cardiovascular disease and injury, whether it's cancer, whether it's lung disease, you're going back to the same hallmarks of aging. And then we can look at dementia. And if you look at dementia, it's like the fourth cause of death here. Symptoms of dementia: memory problems, loss of ability to do everyday tasks, depend on others, increased confusion, reduced concentration and attention, difficulty planning, organizing, difficulty finding locations. And if you remember from that longitudinal study, we talked about when they looked at subjects from age 26 to 45, and they looked at adverse expressions of aging, the very clear indications that someone was aging was their cognitive function was going down, right? So ultimately, when you look at dementia, it's basically a protein aggregate disorder. These tau proteins that are normally part of the cell structure, there's inflammation, they start to break up. And then as these proteins start to break up, they start to aggregate together, and then you get all this protein aggregation, and these protein aggregation creates different types of tangles, and these different tangles get in the way of normal neurotransmission. And then you get this expression of brain atrophy that then tends to express first in the hippocampus, where you start to have long-term memory issues, and as time goes on, will progress to other areas of the brain. But ultimately, all the main mechanisms of hallmarks of aging are associated with cognitive decline. So what it goes to say is for example, if you can change your DNA, if you look at the hallmarks of aging, if you can change your DNA damage, if you can improve your mitochondrial efficiency, if you can improve autophagy, not only are you improving things like resiliency, but you're also reducing your risk for all the top common causes of disease, because they just have the same pathophysiology just happening in different cells and different tissues. Now, when you're looking at aging, for yourself, for your loved ones, for your patient population, the aging process initially starts with what's called subjective cognitive decline. Patient notices the cognitive decline themselves, but no one else really notices it. So they notice that they can't do things cognitively as well as they used to. No one else notices yet. Loved ones, family members that live with them don't notice that yet. Then as they progress, they get mild cognitive decline. This is where family and friends start to notice. And this is where, people start to jump in and, just go, okay, I'll take care of this task in the family because, you've had some problems with that. Whatever that may be. It's when intervention starts to take place. And then when people lose the activities of daily living, like just being able to drive, being able to pay their bills and so forth, that's when diagnosis of dementia is. And if you look at the 7 stages of dementia, this is a progressive condition. And as these start to express, what's happening is, as they go through these different stages, they're having all the different hallmarks of aging show up. That's the mechanism. They have more free radicals in their system. They have senescent cells causing inflammation. The beta amyloid plaque itself causes inflammation. Those protein clusters that aggregate together, the proteasome, become highly inflammatory. The ability to clear those out becomes a problem. Mitochondrial dysfunction. So these are all hallmarks of aging being expressed, then causes the progression of Alzheimer's disease. Now, when you look at various forms of dementia, it's not Alzheimer's disease being the most common one. This is a chart of key clinical symptoms, exam findings, and imaging. And we went over this in great detail in the Cross Institute Cognitive Decline course. So if you really want to go deeper into that, you may want to check that out. But every single one of these is associated with expressions of hallmarks of aging. Whether it's Alzheimer's disease or vascular dementia or Lewy body disease, frontotemporal dementia, CTE, brain trauma that then progresses to dementia, cerebral cognitive affective disorder, these are all going to get worse really because of hallmarks of aging being expressed. Okay. Now, if we go down the path, then we look at digestive diseases. So digestive diseases, again, you can see there in the top causes of death worldwide. Obvious ones: heartburn, abdominal pain, changes in bowel habits, changes in stool color, blood and stool, nausea, bloating and distension. These are all warning red flags, but many times people just have chronic bloating and distension for years and years, and they then find out they have a serious bowel disease. So these are the most common ones that are involved. I mean, people do die from gastritis all the time, especially as they lose resiliency and get older. And people actually do die from celiac disease. People do die from Crohn's disease. And the ones who die? The ones who die are the ones who lose resiliency. Just like the ones who died from COVID and the pandemic are the ones that didn't have resiliency. So that's the key thing, is these gastrointestinal conditions can be triggered by some kind of expression, like someone develops celiac disease or ulcerative colitis or Crohn's disease, which are autoimmune destructions of the gut. But ultimately what causes them to not be able to recover and not be able to attain homeostasis is they have greater expressions of the hallmarks of aging. Because that intestinal inflammation then starts to cause DNA damage and telomere attrition and mitochondrial coupling and mitochondrial injury, and it's causing those expressions even systemically, but more so in that localized tissue. And at some point, if those express to the point they can't recover, that's when people die from it. So this is just a diagram of a great paper you might want to check out called The Aging Gut Microbiome and Its Impact on Host Immunity, and it just goes on to show that just like all other tissues of the body, the gut does age. People assume their gut is always going to be the same. Their 20-year-old gut the same as their 60-year-old gut and 50-year-old gut. It's not the same. It's not going to recover as fast, not going to repair as fast. It's more prone to permeability. It's more prone to having dysbiosis. It's harder to develop microbiome diversity with it. All those things take place, especially if the hallmarks of aging are expressed in the gut. And then when you look at different microbiota and different tissues throughout aging process itself, the key feature is there's less diversity everywhere. Whether it's the urinary tract microbiome or the nasopharynx microbiome or the lung microbiome, they all lose diversity with time and aging. So everything becomes more vulnerable for dysfunction disease. Then you have kidney disease. And kidney disease, again, if you look at it, it's up there, most common cause of death. And obviously when warning signs of kidney disease are change in urine frequency, change in urine color, excess foaming. Excess foaming means there's lots of protein in the urine. So if you have lots of foaming in urine, that's proteins. Swelling and edema in the legs and face, muscle cramps, itchy skin, nausea and vomiting. And most common cause of renal disease are basically glomerulonephritis, polycystic kidney disease, autoimmune kidney disease, renal cancer, diabetes, renal stenosis. And once someone ends up on dialysis, they basically have a 5 to 10 year period of life. And the stages of kidney disease are, you guys are familiar with them. You have to look at the proteinuria in combination with your GFR rate, glomerular filtration rate, to know what stage they're in. And as they get into end stages, life expectancy goes down pretty quickly. And here you can see, ultimately, when you're looking at mechanisms that are impacting kidney disease, kidney function, it goes back, again, to the hallmarks of aging, things that cause mitochondrial impairment, things that cause inflammation, and different various factors involved with that as well. You can see sirtuin genes involved. And this was a paper, Pathophysiology of the Aging Kidney and Therapeutic Interventions. And they go, hey, listen, whether someone has diabetes or hypertension or something that's damaging their kidneys, what we can do is why don't we just incorporate mechanisms that impact hallmarks of aging, like caloric restriction, think about their sirtuin genes, trying to calm down their inflammatory reactions and mechanisms there, trying to calm down their inflammation, their inflammaging, and see if we can treat kidney disease from that way, looking at the model of looking at hallmarks of aging. Ultimately, you want to have decreased expression of hallmarks of aging before you can develop any disease. And the more efficient those systems are, the greater resiliency your person has to recover. And then here is a paper called Molecular Mechanisms of Renal Aging. And they go through and go, hey, here they are again. Senescent cells in the kidneys, senescent associated secretory phenotypes of senescent cells that are taking place, mitochondrial dysfunction, stem cell dysfunction of these nephrotic nephrons and so forth. And then these can progress over a period of time. So kidney disease is, renal epithelium is all ultimately these expressions of the hallmarks of aging. Certain things can turn them on and cause that inflammation and trigger, but at a cellular level, it's these various things. Then we get into diabetes, and you can see diabetes is leading cause of death. It's in the top 10, but for sure the leading cause of blindness, leading cause of amputations, and with very clear symptoms and warning signs of diabetes, you have frequent urination, frequent thirst, increased appetite, fatigue, sugar cravings, and cuts and heals so quickly. In the past, they've looked at traditional complications of diabetes and they're like, it can damage the kidneys and cause peripheral neuropathies. It can damage the blood vessels. But now they're realizing that once someone starts to have diabetes, their side effects are cancers, infections, liver disease, affective disorders, cognitive disabilities, and functional disabilities. These sound like the top 10 causes of death. These sounds like the same exact diseases that are expressed by the hallmarks of aging. So when someone has diabetes, they're really letting you know that their hallmarks of aging starting to express themselves. Now, if you look at the death rates by cause in those with and without diabetes, you can see once someone has diabetes, their rates for all other types of diseases increase. Again, supporting the whole concept of geroscience. Now, the downward spiral of hypoglycemia, people first start to have, blood sugar issues only after they eat. Then they get insulin resistance and start to crave sugar all the time. Then they get metabolic syndrome where they start to gain weight and have symptoms of depression, and the lipid panels go all over the place. Then they become diabetic. Then they become diabetic with high HbA1c, and those glycation end products start to damage their tissues. Then they get complications. And then when their kidneys finally get damaged, that's usually when they end up dying from diabetes. So these are the progressive patterns. We talked about this in the glycemic split diabetes, Crosby-Institute diabetes, and glycemic index course. And when you look at insulin resistance pathways to when someone becomes insulin dependent, so someone has insulin resistance, it could take 15 years for them to have type 2 diabetes, and then another 10 to 20 years for them to become insulin dependent. The more expressions of, or I should say, the more negative outcomes or expressions, the hallmarks of aging they have, the faster this all accelerates. And that's just the chart going over the different ranges we talk about in the course, if you aren't familiar with it. And then you go back to what's happening with diabetes. Well, there's things happening at the beta cells. They also find things happening with fat tissue. So fat tissue has adipocytes. Adipocytes and adipokines help modulate inflammation. They control appetite. And we know in the actual fat tissue itself, it's becoming dysfunctional. There's DNA damage, there's telomere dysfunction, there's stem cell dysfunctions. The levels of adiponectin, which is protective, are altered. There are adipokines that are inflammatory are activated. All of these things promote diabetes. And then within the beta cells themselves, they see the whole senescent cells and mitochondrial dysfunction and stem cell immune exhaustion, the whole inflammaging mechanisms that take place. Here's another diagram that's showing you, if you really take a look at what's happening with the pancreas, they're getting mitochondrial impairment, inflammaging, senescent cells that are creating inflammatory mediators, and so forth. And the same thing happens when you look at liver disease as another cause of death. Obvious red flags for liver disease are jaundice and abdominal pain and swelling, loss of appetite, nausea, vomiting, tendency to bruise. But when people develop liver diseases, cirrhosis is the main concern. And, go from a healthy liver to fatty liver deposits, to scarring, to cirrhosis as the main mechanism. And what tends to really cause expression of these are infections and toxic insults, and even some genetic issues. But when you look at causes of cirrhosis that lead to death and causes of liver disease that impact longevity, really you got to look at viral infections. So specifically hepatitis C being the main one. So the most common cause of cirrhosis here, which are about 94% of them, is viral hepatitis, 40% of it being hepatitis C, alcohol abuse being 18%, hepatitis B being 15%. So that's the 94%. As a clinician, do you know how to identify hepatitis? Well, listen, on your blood test, your transaminases are going to be high, SGOPT, SGPT, GTP. That's not enough. The other key factor that's a red flag is their white blood cells are high. The anytime you see white blood cells high, that's SGOPT, SGPT, you want to, at the very least, start looking at some hepatitis C antibodies, especially hepatitis B and C. And then we'll get into how to evaluate these in the evaluation section and liver disease with more detail and looking at things like FibroSure to look at the degree of cirrhosis. But the point is that ultimately what progresses into death is going to be hallmarks of aging. These other factors are not as critical. But when you're looking at a young liver versus an old liver, and also when you start looking at cirrhosis of the liver, it's really the same thing, like every other one of these tissues. Senescent hepatocytes start working, inflammaging, immune senescent cells start to take place, and the liver can't recover and respond. Now, suicide is always in the top 10 major cause of death, and suicide rates have gone up. They're starting to go up more and more with children. There's been an explosion of suicides in the past few years when people are isolated with the pandemic. And even though the pandemic resolved, the rates of suicide are still pretty terrible. And it's one of the things that keeps growing, even unrelated to the pandemic, each decade. So the warning signs of suicide: depression, sudden calmness, withdrawal from others, loss of concern with appearance and for responsibilities, threatening or discussing suicide. Those are all the red flags. And when you look at the causes, the top 10 causes of death, you see suicide in the top 10. And then drug use is 9, but drug use and suicide are commonly associated together. And if you look at the annual deaths from alcohol, drug, and suicide in the U.S., you can see it's just jumped up. Even before the pandemic, you can see a huge spike here, 2019 during the pandemic. But even before the pandemic, there's this increase in death and suicide. And in the mood disorders course, we talked about depression. I mean, you don't just go on to commit suicide. You always start with having depression, major depressive disorders first. So major depressive disorder is someone who's got 5 or more of the symptoms of depression for greater than 2 weeks. And the outdated model was like, oh, this is just a serotonin imbalance, or this is just like kind of dopamine imbalance. But really, all the current research we discussed in that course is like it's really related to inflammation of the brain. And different mediators that cause inflammatory responses within the brain and decrease frequency of firing activation of that frontal cortex and that limbic system. So this can happen from various mechanisms, but ultimately hormonal issues, inflammatory issues can be a factor. So then we went through this list in the course. We talked about hormonal imbalances that can decrease postsynaptic activity, reduce mitochondrial activity, and these things can cause dysfunctional neuron signaling. So when you look at major depressive disorder, when the frontal cortex and limbic regions have their frequency of firing or their brain activity go down, that's when a person gets depressed. So hormonal imbalances have been shown to do that. And then when people get treatment, for example, this is a person with hypothyroidism with depression, they do a FDG PET scan to look at brain activity. And when they go on thyroid hormones, the areas of the frontal lobe, the anterocingulate gyre cortex in the limbic system, the frontal lobe starts to turn on right away. So we know that when people become hormone deficient, this can be a factor. It doesn't have to be thyroid hormones. Testosterone and estrogen have the same effects very powerfully. I mean, all hormones have some degree. Testosterone has a huge impact on men. Estrogen has a huge impact on females, and thyroid hormones have a huge impact on both males and females. Neuroinflammation is also a major mechanism of causing depression, and it just reduces mitochondrial ATP output, impairs synaptic activity, it slows down nerve conduction speeds, causes more protein aggregates to turns on the kynurenine pathway, causes excessive neuron pruning, and also promotes and triggers all the hallmarks of aging. So you can have inflammatory responses leading to major depressive disorders that leading to suicide. And there are some papers and researchers that think when people have severe inflammation in their brain, that's really when they hit the suicidal tendencies to take place. So there's this inflammatory component to it. And they've also found direct relationships and correlations between inflammatory markers and prognosis of depression. When they've done studies, this is one of these papers, they found all these inflammatory mediators changed. And also what they found is things like SSRIs have a short-term effect on dampening brain inflammation unrelated to neurotransmitter activity. And really that, depression may be a key factor. And for people that have really chronic progressed depression and become suicidal, neurodegenerative diseases are a key factor. Alzheimer's disease, frontotemporal dementia, Parkinson's disease. Their brain just degenerates. They have less neurochemical substances there. They can't activate their limbic system as well. They get depressed. And they get to the point where they may even become suicidal. Blood flow dysfunction to the brain can have those impacts. So ultimately, when you look at these mechanisms that are associated with major depressive disorder, which can then be linked to depression and suicide, these are all mechanisms that are also overlap with hallmarks of aging. So inflammation in the brain, astrocytes get activated, inflammaging starts to take place, the injured tissue starts to create problems, you get stem cell senescence, you get mitochondrial uncoupling, and so forth. And I would say the greater expressed your hallmarks of aging are, the more prone you are for depression and for things like suicide. And then the last major cause of death, Parkinson's disease. And Parkinson's disease rates and trends in mortality for Parkinson's disease have been gone up. It's one of those things that has not gone down with time. It's gone up with time. So people dying from Parkinson's disease. And the warning signs of Parkinson's disease: slowness of movement, chronic constipation, hip and shoulder stiffness, softness of voice, and muscle tightness. The initial complaint of Parkinson's disease is constipation. So someone will come in without any tremors and just have chronic constipation for years and years that no one has been able to fix. They're the weird, difficult constipation patient no one can figure out. They have such a mysterious microbiome. They don't. They have Parkinson's disease. They have alpha-synuclein protein aggregates all throughout their enteric nervous system, so they can't move food. And it's going to eventually progress into other areas of their nervous system and brain, from their enteric nervous system up the vagus nerve and up to the brain, and they'll start to get tremors in those pathways involved as well. So if you look at Parkinson's disease prevalence, it definitely increases with age. Now, when you look at mortality from Parkinson's disease, when a person is first diagnosed with Parkinson's disease, they're often told, you will die with Parkinson's disease, not of Parkinson's disease. This means Parkinson's disease is not fatal disease per se. End of life often occurs in old age from another medical illness entirely. Complications can arise, Parkinson's, including infections, falls, motor dysfunction, and leading to suffocation. So what happens with Parkinson's disease, and its worst scenario, is they lose their motor activity. They get stiff, they get rigid. They can't expand their lungs. So their intrinsic respiratory muscles stop working. They get really stiff. They can't take in deep breaths, and then becomes very prone for them to suffocate. And they're having a very hard time if they get a respiratory infection to recover, since they can't really expand and move their lungs and oxygenate. And they're also prone to getting falls that then leads to death from various issues associated with that. So you want to be able to identify early Parkinson's in your office as well, because if you find it early and you can start to do interventions and slow down the progression of it, it can be very useful. The main issues we talk about in the dementia course all apply to the Parkinson's disease, but you really want to get them to move, do a dynamic response with complex movements, and studies have shown things like kickboxing and high movements and high coordinate activities and burst activities can really be protective. But everything we're going to talk about in this course, the hallmarks of aging, like improving resiliency and autophagy, try to promote autophagy and trying to increase cold shock proteins and heat shock proteins and doing caloric restriction, immediately all apply when it comes to Parkinson's disease. So as soon as you start to see the early signs, like they have a soft or low voice, you have to keep asking them to speak up. A masked face means they're having increased tone in their face, so they're not having lots of facial expressions. And most people think that the patient looks angry with them. Because usually when people are communicating, their facial muscles are moving back and forth, and you get some feedback that way. But when people are angry, they just stare, and for them, they have rigidity and stiffness. So it looks like they're staring. Other key thing you'll notice is they just don't blink as much. Dizziness, fainting is a common thing. Hunching over is really when they're progressed. You see people that lose their postural reflexes. They start to bend forward. Loss of smell is another one. Peppermint, anise, coffee are the most common smells they have. Tremor or shaking is like end stage. If you're waiting to see tremors, you're going to miss most of your Parkinson's disease when it's too late. So the tremors they have is also a resting tremor. So they have tremors with rest. And the key feature of finding a Parkinsonian tremor is you do this. You have a resting tremor, you have them do a wing beat. And in a wing beat, so they have tremor here. Again, do it. So they have a tremor down here. They do a wing beat, it stops, and then it reemerges. That's the classical Parkinsonian tremor. Okay, they call that a reemergence tremor. And they get stiffness and rigidity usually in their shoulder or hip. So they get a frozen shoulder, frozen hip. Handwriting gets smaller because as their muscles get tighter and they get cramping, their handwriting font gets smaller. So we'll do a handwriting test where we have them repeat sentences, and you'll see their font size change as they start to write more and more sentences. They have trouble sleeping, and one of the key things that also happens with early Parkinson's disease, is they start kicking and punching their spouse in bed, and a lot of times they'll have to sleep in separate beds. That sometimes is the earliest indications of Parkinson's disease. You just have these violent things, and and then people go, "Oh, it's past trauma coming up. It's emotional issues. It's all nope. It's just abnormal muscle tone activity developing from dysfunction in the basal ganglia." And then we would talk about constipation. So constipation is another main one. This is a chart I made. Just goes over the main symptoms with Parkinson's disease, and then the progression. You're not gonna if you wait here for Parkinson's disease, you're gonna have very little potential clinical impact. You really want to find Parkinson's disease with rigidity and stiffness, posture instability, all those things first. Okay. So those are the most common causes of death. These are what you have to be able to figure out. If you look at geroscience, these are all directly linked to the features of geroscience, which are these mechanisms, meaning whether you're looking at respiratory diseases and lung tissue and digestive diseases in the gut, or kidney diseases and nephron, or the brain and looking at neurons. These are the things that are actually happening in those tissues. So there's a lot of truth in the mechanisms of these cellular changes happening first that then leads into chronic inflammation in those tissues and aging processes that then get expressed as diseases. And when you're looking at preventive medicine and longevity, these are the things that you want to change the expression of before they get into these diseases. Sometimes it's too late, but you got to find these diseases early. You can still implement all these strategies to modify the expression of the hallmarks of aging to make it change. And this is where we get into not from wellness, where you have to identify disease early, but looking at risk factors. So looking at risk factors is really all to do with resiliency. So all the hallmarks of aging can impact physiological resiliency. And one of the key concepts we talked about is one essential feature of centenarian biology compared to those with reduced lifespan is they have improved physiological resiliency. And then in the first lecture of the course, we went over different studies that really talked about that's what they see as the key physiological difference between people that age well and centenarians and everyone else is that they have really good resiliency. So, decline in biological resilience is a key manifestation of aging. So as a clinician, you're not going to be able to measure everyone's telomere length in every single one of their tissues, and look at all the different biopsies of every tissue to figure out how old their tissues are. But you can see change of resiliency in every part of their tissues. And that could be a major clue to you that they are starting to age. So when you look at the big picture here, you have genes plus environment that then cause a phenotype, right? Genotype plus environment, how those genes express become a phenotype. This phenotype is going to have different hallmarks of aging expressed. And as these hallmarks of aging get expressed in different tissues, you'll start to have different resiliencies that are impaired. So if there's greater hallmarks of aging expression in the immune system, then you start to get immune resiliency. If different degrees of stress impacted and different degrees of hallmarks of aging expressed in neuroendocrine pathways associated with stress resiliency, then you start to have loss of someone's ability to tolerate stress. So we're going to go over these resiliency patterns in a little bit more detail. It's an early stage before someone gets disease to look at these factors. Diseases, the expression of these being unnoticed and going on for too far. But decreased tolerance, decreased function, decreased endurance, decreased recovery, these are all red flags. So function is easy. We see that all the time in functional medicine. They can't function as well with various aspects of their life. Tolerance, we see all the time. Tolerance is food tolerance, chemical tolerance, immune tolerance. Another key one is endurance. Cognitive endurance, physical endurance, and then recovery. Can they recover from a cold? Can they recover from a workout? Can they recover from a autoimmune flare-up? Has that gotten worse over the years? And then, those are important. We've already talked about disease development. So these are the different clinical presentations with loss of resiliency for all the different tissues in the body and all the different types of resiliency. So I made that chart for you to just kind of go over those, and then we have a checklist for those to go as well. And then these are all the different types of resilience. Remember that different people have different degrees of resiliency in different areas. The goal is to have all of the different degrees of resiliency to be at least good. Once they start to become poor, that's when you start to have issues and concerns for someone's general health. And centenarians have really high resiliency. This is someone who's got some red flags popping up here. You can see inflammatory resiliency is going down, thermal resiliency is going down, stress resiliency is going down. And you want to evaluate yourself, see where you are with these resiliency patterns. The key issue is centenarians have these high resiliencies all throughout their lifespan. People that have unhealthy aging are going to have these resiliency patterns like this, where everything is poor. So that's just guaranteed to have it. And whereas someone that's got really high exceptional resiliency will be those that age well and have great longevity, disease prevention. And also, if they get a disease, be able to recover pretty quickly with them. So let's talk about pathogen resiliency. So your immune system can age. Your immune system can develop what's called immunosenescence. And immunosenescence means the coordinated response from when a pathogen enters your body and how you respond to get rid of the pathogen can become less efficient. And that can happen because the signaling pathways between immune cells are not functioning as well, so-called hallmark of aging, loss of intercellular communication. That could happen because you're not making as much immune cells, like hallmark of aging patterns like stem cell exhaustion. And that can also happen because you have lots of inflammation dysregulating immune pathways from lots of protein aggregates called inflammaging. You could have stem cell exhaustion. You can have senescent cells, all those different mechanisms. So here you see like an illustration of like virus, bacteria, fungi, parasites come in. And when these come in, there has to be a normal immune response against them. So here is a slide. You can see antigen. First thing that comes in is an antigen. We get exposed to antigens all the time. The initial response to an antigen is like a macrophage or antigen-presenting cell engulfs that antigen and then starts to create signals to call for help. So here you can see an antigen and an APC, antigen-presenting cell. And this antigen-presenting cell then calls for help, releases cytokines to activate T helper cells. T helper cells then call in the soldiers of the immune system called natural killer cells and cytotoxic T cells. They come in and try to destroy the antigen. The antigen-presenting cell and T helper cells calls in B cells. B cells start to make antibodies that make proteins to find these antigens much faster. So these natural killer cells and cytotoxic T cells can destroy them. And then the suppressor system, T suppressor cells come in to suppress the whole antigenic response once the antigen's been destroyed. So the inflammation doesn't continue on. Then you have regulatory T cells that kind of control these two. And then the left-hand side is what's called a Th1 cell-mediated response. Th2 is a humoral response. Th2 is the humoral, right side is a Th2 humoral response. So these antigen responses are all depending upon the effectiveness and age of the immune response. And different viral infections can be an issue. Some people lose their viral resiliency. So there's acute infections like influenza, rhinovirus, SARS-CoV-2. They cause acute immune response until antibodies are formed, and then the person recovers. People get latent infections. Latent infections are chronic infections that reactivate themselves. They stay in the tissues, like herpes virus, cytomegalovirus. The next Carotid Institute module is actually on clinical applications to chronic infections. We'll be talking about this pathway a lot. And chronic persistent infections like hepatitis C, and then progressive infections like HIV. So the one you're going to obviously be most concerned about and see more often is people that get acute infections that just don't recover, or those that have latent infections that keep getting a reactivation, and hepatitis C, those that just can't get their viral load down. And those are all associated with impaired viral resiliency. So one of the resiliences we have is impaired viral pathogen resiliency, susceptibility to viral infections that constantly get whatever's coming around every year, all the time, no matter what. Reoccurrence of latent viral infections, significant tissue injury with chronic persistent viral infections. So they get a viral infection, but they get systemic inflammation all throughout their body. And that's what you saw with people that had cytokine storms and significant manifestations of SARS-CoV-2 recently with the pandemic. Acute viral infection recovery is prolonged. There's like your long COVID pattern, severe immune response to viral infections. And those are impaired viral pathogen resiliency. When you see patients come in with long COVID syndrome, which is a common feature now in our society, the key thing to remember is it's just telling you that they've lost resiliency. And by the way, when you lose resiliency in one tissue, you probably have lost resiliency in other tissues. So if you see like a 40-year-old having long COVID and you have a 40-year-old that had a severe response to the pathogen, those should be some red flags to look at resiliency a little bit more detail. Now, besides viral resiliency, there's mold resiliency. And one thing to understand about my mold exposure is that what the researchers have found is when people get mold exposure, we're talking about toxic mold exposure. When they get toxic mold exposure, they initially have a mucosal general immune response against it, and their IgG, IgM reactions go up and have systemic inflammation. There's a percentage of these people that then, with chronic exposure, start to have their IgE response go up. And that's when they get lifelong allergy to mold. Those are the ones that, from that initial insult, whenever they go into a room that has any kind of mold species in there, like a damp building, they start to have symptoms come up and they feel awful and they get headaches and fatigue and whatever set of symptoms that they normally get when their immune response reacts against them. So these mycotoxins, these mold species also break down the barrier system and they cause systemic inflammation and so forth. So one of the things to look at people that have impaired mold pathogen resiliency is when they get exposure to damp or water damaged buildings or poor ventilation in rooms and or humidity gets greater than 50%, that's when they have some problems. So noticeable symptoms of impaired mold resiliency is noticeable reactions when exposed to mold, symptoms develop in damp or water damaged buildings, notice improvements in symptoms and function when outside some buildings, muscle pain, joint pain, often experience wheezing, shortness of breath, nasal congestion, itchy eyes. The reason I'm telling you all this, by the way, is whether they have like mold pathogen resiliency or viral resiliency, we're going to just activate the expression of the hallmarks of aging and see if they change, right? So if you have someone who's got mold issues and mold resiliency patterns that have developed, or they keep getting reinfections, or they have long COVID, if you can turn on cold shock proteins and heat shock proteins and turn on autophagy and protect DNA, genome instability, and look at all the clinical implications of longevity medicine, they may helpfully improve the resiliency for these factors. You're not really trying to treat mold or treat the virus. You're just trying to treat their physiology that would make these systems all more efficient. That's the key thing. Then you have another pathogen as far as resiliency, parasite pathogen resiliency. And you have to realize there's a lot of people that have parasites in their gut that have zero symptoms. And in the autoimmune course, we went over a lot of research that shows some parasites are actually very protective. And they're now using different proteins that parasites release in animal models to cure autoimmune disease, because some of these parasites release these mediators that have these autoimmune modulating effects. But when people lose their gut resiliency, they have severe reactions to parasites. So you can see, like clinically, you have someone that has a parasite. Let's say they have Blastocystis hominis on a GI panel, and they have no GI symptoms, so they decide not to treat or do anything. And then 3 years go by, and now they're under high amounts of stress. They're not getting enough sleep. They have other factors impacting their health. And all of a sudden, their parasitic expressions get really, really severe. That's the point that they've lost some of their gut resiliency patterns. So people that have impaired gut resiliency are prone to parasitic infections. If they're eradicating parasites, another key one. People that don't have enough integrity of the gut immune function, you can go on many, many anti-parasitic interventions that may not respond. So again, interventions to try to improve longevity expression may be something you consider with people that have difficult bugs that you can't get rid of, like parasites. Also, if someone has really poor aging and they lose their hallmark of aging physiology, they just don't make enough mitochondria, they have lots of genome instability, you may not be able to get rid of parasites with them very easily. Okay. And then impaired bacterial pathogen resiliency, susceptible bacterial infections, these are the ones that have a chronic bacterial issue all the time, like gastritis, bronchitis, pneumonia, sinusitis, urinary tract infections, resist antibiotic therapy. These are all impaired bacteria pathogen resiliency. And then as we look at immune resiliency as a general thing, the ability to maintain immune cells and avoid expression of chronic inflammatory immune triggers and also cancer, we have to have lack of immune senescence develop. So indications that the person has lost their immune resiliency or immune senescence, they have chronically low white blood cell counts, chronic lymph node swelling, susceptibility to infections, prolonged recovery from infections, diagnosis of autoimmune disease, diagnosis of cancer. And if you look at all the mechanisms that are used to treat cancer from a lifestyle perspective, or to help support the body to help fight cancer is a better way to see it, not to treat it, but to help support the body's ability to fight cancer. What do people do? They fast. They put them on a ketogenic diet. They give them off all sugar. These are all the things that improve nutrient sensing pathways. Autophagy. They try to activate senescence. They do things like cold plunges. These are all the things that they're trying to do that are overlapped with many things that people do for Alzheimer's disease, that are overlapped with many of the things that people do for longevity medicine. So, it's important to pick up those patterns. So the other key thing is microbiome resiliency. You want to be able to identify microbiome resiliency. So the microbiome has to be diverse. You have to have lots of bacterial species, different bacteria can have different functions that they engage with someone and throughout their system. When people start to lose their microbiome resiliency, they get dysentery with diet changes whenever they're chore or when traveling. So as soon as the diet changes, they have problems. That's a major sign that there's lack of microbiome resiliency. Gastrointestinal symptoms from changes in hormones. There's some people that whenever they get their menstrual cycles, their gut goes crazy. That's a sign that there's lack of microbiome resiliency. So the microbiome resiliency means your bacterial species can adjust and change their populations when stressors are given to them. Stressors to the microbiome could be food proteins, and hormones have a huge impact on microbiome expressions as well. So changes in hormones that change the microbiome and gut is an indication. Sometimes it's stress hormones. Sometimes it's reproductive hormones. Sometimes it's thyroid hormones. Gastrointestinal symptoms from changes in exercise frequency and intensity, gastrointestinal symptoms from stress and psychological challenges, inability to tolerate probiotics, prebiotics, fiber supplements. These are all signs that there's loss of microbiome resiliency. And then as we get into loss of stress resiliency, that just means the feedback loop between areas of the amygdala, hippocampus, and autonomic nervous system are starting to lose their integration and function. So the signs of impaired stress resiliency are sleep disorders when under stress, immune weakness when under stress, depression, anxiety, and rage when under stress, gastric burning when under stress, promotion of dysglycemia when under stress, microbiome disturbance when under stress, weight gain or weight loss under stress. These are all signs of impaired stress resiliency. And then we have psychological resiliency. And, the key thing is with psychological resiliency to have, practice positivity, manage emotions, clarify purpose and meaning, reframe thinking. But ultimately, does everything suck all the time? And can you handle some degree of stress? If everything sucks all the time and everything is end of the world, then you don't have good psychological resiliency. So you have to have some degree of optimism. And by the way, the psychological resiliency is one of the main features of centenarians. They didn't completely fall apart when they were faced with a psychological life challenge. Okay? Those that fall apart with the slightest little thing have a problem. I worry about some of the younger people that have someone post something on their social media site and the end of the world happens. You're like, wow, you're really training yourself to have no psychological resiliency that has far-reaching health implications down the road. Anyways, psychological stressors. So impaired psychological resiliency is going to be people that have impairment or function with psychological stress, inability to socially communicate when under stress, psychological stress, perseveration about negative stressor. That's perseveration means they just can't stop talking about it. When you meet the person, they just keep going to tell you about whatever the stressor was over and over again, and that's always going to be the conversation. That's poor psychological resiliency. They can't let it go. Okay, unable to find positive outcomes, development of mood disorder from stressor. These are people that have poor psychological resiliency. Okay, and also when they did the longitudinal study that we went over at the beginning of this course, in this section, in addition to cognitive decline and astrophysical appearances of aging, another key feature they saw with poor aging is loss of psychological resilience. So it's key. Okay, and then we get into cognitive resiliency, the ability to handle cognitive challenges. So remember, it goes from subjective to mild cognitive impairment to dementia. Impaired cognitive resiliency symptoms include reduced attention span with concentration and cognitive tasks, impaired short-term memory, impaired long-term memory, typically planning and organizing, typically learning. These are all parts of impaired cognitive resiliency. And then we get into thermal resiliency, inability to handle cold or hot temperatures. Now, I guess for some people, they can have lifelong, they can't handle cold or hot, and especially cold, like the amount of brown adipose tissue you have, which a lot of it is genetically determined, is going to be a factor of how much cold intolerance you can handle. So people have really efficient and high amounts of brown adipose tissue. Brown adipose tissue is mostly found behind your sternum. Is what really adapts a person's thermoregulation system. The key thing you're looking at for is a loss over time. All of a sudden, they can't handle cold temperature as much. All of a sudden, they can handle hot. That means they're actually losing their resiliency. It's not what their baseline levels were. So when people have issues with temperature going up or temperature going down, these things are associated with thermoregulation resiliency. So impaired cold thermal resiliency, unable to handle cold temperatures, less tolerant to change in temperature, getting colder. They're always the ones that have to layer up and wear scarves and completely miserable when there's just like a little bit of wind. And if that's getting worse over time, that means they're losing their thermal resiliency. And then same thing with warm temperatures, unable to tolerate warm temperatures, must use air conditioning to function when temperature's hot. Those are all impaired thermal resiliency. And then you get into toxicological resiliency. This is the ability to quench, metabolize toxins. And, we're exposed to air pollution, water pollution, soil contamination, pesticides all the time. And then with the way we resolve these exposures, we have free radicals that quench them. And then we have our liver phase 1, phase 2 pathways that clears them out of our system. They convert them into a water-soluble end product so we can eliminate them through our urine and sweat and feces. And then the microbiome also has phase 1, phase 2 biotransformation pathways. So they're also involved with getting rid of our toxic load. So as our phase 1, phase 2 pathways become compromised in the liver or gut, as we get older, we start to have toxicological resilience. So the symptoms of impaired toxicological resilience are increased reactions to chemical odors, adverse reactions in air pollution environments. Some people get headaches. There's people that go to like Asia and highly polluted air pollution areas like Beijing and are sick the whole time they're there. And can't handle it. The minute they get off, they get into a hotel room and breathe there with a filter or something, their symptoms change. The minute they walk outside, boom, things are worse. People have symptoms immediately from looking at air pollution outcomes for that day and wherever they live. They look at those readings, and if it's really air polluted, they know they're going to have symptoms. So when the sensitivity to air pollution becomes much worse, that's a loss of toxicological resilience, skin reactions with chemical exposures, noticeable change in functions and health when exposed to chemicals, toxins, pollutants. Those are all signs of impaired toxicological resilience. And then dietary resilience, just people that react to dietary proteins. This is something associated with immune tolerance. We went into this with great depth in the autoimmune course. We're not going to review all that. But over time, people lose their gut immune function reacts to proteins. Their dendritic cells in their gut get really overreactive. Their microbiome, Treg cells become dysfunctional, and they start to react to all different types of proteins. And when people have reactions to foods as they get older, dietary protein tolerance, some of it is this loss of oral tolerance, and some of it is they just can't digest their food. So here's a chart of all the different reasons why people may have different types of physiological responses to foods. A lot of the food intolerance issues are immune related. Some of them are maldigestion related, and so forth. And then I put together a list for you of specific food exposures that can give you clues to where some of these dietary intolerances are coming from. But when people have impaired dietary resiliency, they have increased reactions to different foods, unable to digest protein-rich food efficiently, unable to digest high-fat foods efficiently, unable to digest starchy foods efficiently. These are really more due to maldigestion. Reactions to different foods are really more to do with oral or immune tolerance. And then inflammatory resiliency just means they're more prone to inflammation. So the Karazian Institute pain and fatigue course, I think it was fatigue and pain course actually. Fatigue and pain course, we talked about all the things that activate nociceptors, and those are just inflammatory mediators. When people have exaggerated responses to these, those are clues that they've lost their inflammatory resilience. So the main symptoms are experiencing pain more frequently, stiffness in the body, throughout the body, increased episodes of brain fog, exaggerated responses to dietary and environmental allergens. These are all signs of impaired inflammatory resiliency. And then physical resiliency is basically just having an ability to respond and work out as well as you used to. And there's research that clearly shows that your antioxidant capacity and your mitochondrial fitness is going to determine whether you fall apart from exercise or not fall apart from exercise. We're going to go over this in more detail, but the symptoms of impaired physical resiliency are recovery time is prolonged after workouts or physical tasks. Endurance time is reduced with exercise or physical tasks. Physical intensity is reduced with exercise or physical tasks. Injury prone with exercise or physical tasks. Those are all the main ones there. And then blood sugar resiliency is the ability to really handle a meal without crashing or not crash in between meals. So normal blood sugar levels should be stable throughout the day. Hypoglycemia means you can't maintain your blood sugar levels between meals. It drops. These are the counter-regulatory mechanisms that prevent your blood sugar from dropping. Glucagon's released, epinephrine's released, cortisol is released. There's an inefficiency in those pathways. That's an issue. And in the Crohn's Institute Diabetes and Dysglycemia course, we went into like loss of resiliency from blood sugar issues for hypoglycemics. And then for people that have insulin resistance, they usually just have dysfunctional insulin responsiveness of the receptor site. So they have high blood sugars. And then also sometimes when they get insulin surges, they get into hypoglycemic states. They get this roller coaster ride. And then ultimately the mechanisms or the insulin receptor site is not responding that are causing these shifts. But the key thing to talk about now is symptoms of resiliency. So impaired blood sugar resiliency, unable to eat meals without fatigue, must use coffee or nicotine after meals to function, reduced tolerance to sugars or carbohydrates, unable to function long without meals. Those are all signs of impaired blood glucose resiliency, right? And then finally, sleep resiliency. Symptoms are inability to fall asleep, must use medication or nutraceuticals to fall asleep, unable to recover from sleep, must sleep for many, many hours to function. Those are all the main symptoms of sleep resiliency. And ultimately, when you look at resiliency and how to rebuild that, which we'll talk about as we get to the program, is how to develop hormesis to get benefit and then not do harm. And the key concept as we finish off here is to optimize longevity and health, aging, you must improve physiological resiliency. The other part of it is to prevent accelerated aging, you must not exceed parameters of physiological resiliency. So you got to see what you can build, but if you go past it, you will crash, right? And then I made a checklist for you in the course materials of all the different resiliency symptoms. So you can, fill these out for your patients, or your patient can fill them out, and then you can determine what their resiliency levels are. Now, I would suggest just the fact you're taking this course, do this for yourself. All the information here applies to you because we're all trying to live as healthy as life we can, the greater lifespan. Just go through the checklist and see where you are with each one of those things. And remember that the ultimate goal is to have wellness where we don't have disease development. These are the main types of disease we want to make sure we worry about. We're going to go over how to evaluate these in detail when we go into evaluation through a very comprehensive annual physical exam. And then the resiliency factors we went over here, and then you have the questionnaire form to help you with that. So thank you.